Hi, my name is Crystal, and my presentation is titled Improving Chest Compressions During Cardiopulmonary Resuscitation in Intensive Care Units. I currently work in the MICU at the Hospital University of Pennsylvania, and have witnessed many cardiac arrests in the last 3.5 years of working there. My floor has the highest incidence of codes, and so the issues surrounding CPR, such as ineffective chest compressions, has always fascinated me. I'll be discussing my floor's current practice a bit later in the presentation, but I wanted to just mention that my floor is trying to improve chest compressions, and it's mostly nursely driven. We work closely with the clinical practice lead, clinical nurse specialist, and management to improve chest compressions because it is an important topic in ICUs. The reasoning for that is because of the high mortality and morbidity surrounding sudden cardiopulmonary arrests, or CPAs. Outside the hospital, it affects more than 600,000 people worldwide, with an overall survival rate in the US of only 12%. Inpatient cardiac arrests occur 59% of the time in intensive care units, with survival rates from 0 to 36.2%. So it does occur frequently in ICUs, and this, as you can see, the survival rate is very low. The American Heart Association, AHA, recommend quality cardiopulmonary resuscitation with chest compressions delivered at a rate of 100 to 120 with depth of at least 5 centimeters. And so each of the research articles I'll be discussing follows the same AHA guidelines, meaning that the definition of effective compressions must meet the aforementioned guidelines. Early initiation of effective compressions is the mainstay of optimal survival rates. So the problem is ineffective chest compressions. There are varying reasons for this. This could be related to fatigue, competing tasks, access to patients, and limited manpower. So ineffective chest compressions are defined as not meeting the AHA guidelines. This could mean that the compression depth is too small. The chest compression does not end in full relaxation, or it does not meet the rate of 100 to 120 times a minute. Personally, I have experienced all of these things in the codes that I have participated in. Also, just to reiterate again why this is a nursing issue is because ICU nurses are responsible for hemodynamically monitoring their patients. We're often the first to initiate chest compressions, and during the code, we serve as the main rotators of chest compressions as well. My first article is related to the impact of a feedback device. A feedback device is a device that sits on the chest during chest compression, and as the compressor is performing the chest compressions directly on the device will give real-time feedback regarding increasing the rate or increasing or decreasing the depth. And so this article by Boolean assessed the impact of a device called CPR meter on the chest compression quality during an extended CPR mannequins. The randomized control crossover study used 60 professional rescue volunteers performing CPR with the data being recorded on the CPR meter and compared to the AHA guidelines. The study found that the rate of efficient compressions with the feedback device was significantly higher than the group without, 42% versus 21%. This study could help improve ineffective compressions in ICUs by integrating a feedback device due to its doubling the rate of efficient compressions. Limitations of the study include the use of mannequins. So mannequins, they're obviously different from the human body. They do not represent the diversity of patients' chests and changes that occur in chest resistance during extended CPR. The sessions were also performed in a quiet environment, which is a far cry from the loud and hectic code in real life. But the AHA's current recommendations are to switch rescuers every 2 minutes, which can lead to harmful compression interruptions, depending on how long it takes for the people to switch. But as the CPR meter raises the awareness of the rescuer's compression efficiency, this could actually suggest that the switchovers can occur longer than 2 minutes in length, so meaning that the patient can actually receive longer, effective, steadier compressions over time. The next article compares different feedback devices to basic life support. So the three feedback devices is True CPR, CPR Easy, and iCPR, and this was compared to standard BSL without a feedback device in a randomized controlled trial with 140 nurses. The depth, rate, incorrect decompression, and incorrect hand positioning were measured, as well as evaluating the ease and comfort of use and level of confidence in distraction using the Likert scale. Results showed that only True CPR significantly showed differences in the effectiveness of compressions by reducing the proportion of compressions with inadequate depth and incorrect decompression. True CPR also scored the highest in user satisfaction. So True CPR was actually effective 85.6% of the time, whereas the other three methods were all between 33 to 40%. Limitations of the study include the use of mannequins. So as previously mentioned, there are limitations with mannequins. Also, the fact that the study only used nurses is not representative of all the different healthcare providers who do typically give chest compressions, such as other doctors, respiratory therapists, etc. Also, so overall though, this study is significant because it does show that while there are several feedback devices available, not all of them are effective. Some can even be harmful. Improper hand positioning occurred in over 20% when using ICPR, but less than 8% in all three of the other methods. Another interesting fact is that nurses with result of the study is that nurses with higher BMI and more work experience had the highest percentage of effective chest compressions. The results suggest that using a feedback device can lead to more consistent chest compressions regardless of the nurse's experience and BMI, which can be very beneficial as well. The next topic I wanted to discuss was refresher simulations and its benefits. So this study by Chang used refresher simulations known as just-in-time or JIT training in combination with visual feedback, or also known as VIS-F. And VIS-F is very similar to the feedback devices that I had previously discussed. So the results of this study that I'm going to be talking about is going to be focused more on the simulation benefits, not necessarily the VIS-F. But the study used 324 CPR certified healthcare professionals across 10 hospitals in a randomized clinical trial. The VIS-F device provided the information for the chest compression information, while the just-in-time training consisted of a 5-minute standardized CPR training video and 2 minutes of practice. And so the results showed that the combination of the JIT plus the visual feedback resulted in the highest quality of CPR among all the groups. And the results suggested that the training, with or without the visual feedback, improved compliance with AHA guidelines. But of course there are limitations, which include that the training was 45 minutes before the code, whereas obviously in real life we cannot determine when the code is going to occur after you receive the training. And also the recipients only received one training, whereas in reality the hope is to have as many simulations as possible. But overall, the results did show that the chest compressions was 48% efficient when the combination of the training and the visual feedback was used, compared to only 12.7% of the basic life support without any intervention. So this is actually nearly 4 times more effective when a simulation is used and when visual feedback is used as well. But actually, when thinking about it, to say that the chest compressions were only effective half the time with the intervention shows that the quality of CPR is still poor overall. Thus, this suggests that more research is needed about the type, frequency of just-in-time training and strategies to effectively integrate this into practice. So the next thing is the Lucas 2. So the Lucas 2 is a mechanical compression device, and in this prospective observational study, among 696 outside hospital cardiac arrests, 155 cases were treated with the Lucas after 1 episode of manual CPR, and actually just showed that the rate, no-flow time, and the no-flow fraction, which is the amount of time that there is no no chest compressions happening on the patient was actually a lot lower with the Lucas than with manual by 19%, and the Lucas's rate was within AHA guidelines. This result suggests that the Lucas device gives more effective compressions and could potentially lead to higher survival rates than manual chest compressions. However, this was a small observational study. It was not statistically powered to evaluate survival outcome, and end tidal CO2 data and CC depth could not be recorded. This study helps me evaluate the efficacy of a mechanical device such as Lucas 2 as a potential solution to providing higher quality CCs in ICU. The next study actually shows the safety of several different mechanical compression devices, which would be the Autopulse and the Lucas. And the meta-analysis actually looked at the outcomes of nearly 13,000 patients across 7 randomized controlled trials. And it showed that, interestingly, manual compression showed less risk of pneumothorax or hematoma formation than Autopulse. And there's also a higher rate of visceral injuries with Autopulse and Lucas compared to manual. While there were no differences regarding CC efficacy between manual versus Lucas, manual CC was ranked as the most effective strategy to improve survival at 30 days, and also neurological recovery too. The findings questioned the use of routinely using mechanical compression devices and suggest training to improve manual CC among rescuers instead. The study also provides support for companies to improve the fit range of the device and the ease of placing the device on, reducing the time to shock delivery. This helps me recognize that while some research may show increase in efficacy with the mechanical devices, there must be caution utilized due to the safety concerns. So the last studies I thought was extremely pertinent because I'll be discussing shortly about its use on my unit. But first, I want to discuss that at the Hospital of University of Pennsylvania, feedback devices and refresher simulations are not routinely utilized in the MICU. However, the clinical practice lead does organize quarterly skills day, where refresher codes may take place, but only a small proportion of nurses attend, and it is completely voluntary. And yes, so since the beginning of the COVID-19 pandemic, Lucas devices were introduced on my unit due to the highly aerosolized nature of CPR attempts with COVID-positive patients. The idea is that the Lucas device reduces the number of healthcare teams in the room during a resuscitation event, eliminating the need for the group of chest compression rotators. With the previous meta-analysis showing equal efficacy between manual CC and the Lucas is appropriate to continue to be utilized with more training regarding its use, risks, and benefits among nurses and other providers. In light of the pandemic, the Lucas's device has benefits, and despite its imperfections, such as the safety issues previously discussed, the benefits are being more widely recognized. But overall, there is still varying range of knowledge and confidence using the device among nurses. It's still new, and actually there were no formal training sessions regarding the Lucas. It was only mostly word of mouth training and just some discussions during morning nursing rounds to teach about the Lucas. And so even for me personally, I've only used it a few times. I would not be confident in being the one to initiate it alone, but right now there are nurses who are confident in using it, and they're the ones who initiate to put the Lucas on the patient during a real life code. But I definitely think that there needs to be more training so that more nurses are confident in using it. And lastly, the recommendation for future practice in regards to all the researches I just conducted. So the feedback devices can lead to more consistent high-quality compressions and potentially increase the length between rescue rotation. And also, it's great that the quality of compressions is not dependent on the characteristics of the provider, such as BMI. And also, but like I said, only true CPR showed that it's actually more effective, and some devices can be harmful. There should also be more research regarding these devices on real people, not just mannequins. Also, refresher training, such as the MICU skills day I just discussed, I would recommend having more frequent trainings and also making them more mandatory in ICUs. just because the research shows that they can improve chest compressions during a CPR if there are more simulations. And lastly, the mechanical devices such as the Lucas. There is definitely research showing how effective they are, but users must be aware of the safety issues, and also there should be more research to improve it and make it safer. Overall, nurses must continue to improve manual compressions in conjunction with evolving technology.